Hello, everyone, and welcome to another special episode of ACE's hashtag CR Arthritis series from the Canadian Rheumatology Association's annual scientific meeting. Today, we have the pleasure of being joined by a good friend of ours, Dr. Janet Pope, Professor of Medicine in the Division of Rheumatology at the University of Western Ontario and the Division Head in Rheumatology at St. Joseph's Health Centre in London. Dr. Pope, as many as you know, is a leading international researcher in scleroderma, lupus, rheumatoid arthritis, in areas such as outcome measurements, clinical trials, and disease manifestations. Dr. Pope, thank you so much for joining us today.
Thank you, and I'm really thrilled to be here. I think what your group does is really important and key to our topic.
Indeed. And I also want to acknowledge, as if you didn't have enough roles and responsibilities in that storied resume of yours, your leadership at the CRA, where you are chair of the CRA Research Committee. And it must give you great satisfaction to see all the marvelous science that's going to be presented again this year at the annual meeting. And let's talk specifically about a session that you are presenting, and it's titled, provocatively, Research Doesn't End with the Funding. Knowledge dissemination is a must, where you're going to highlight the critical role of knowledge translation and exchange, KTE, in ensuring that research findings reach and benefit patients, healthcare providers, and policy makers, among other stakeholders. Dr. Pope, I'd like to ask some questions to help our audience understand your thoughts in the presentation.
Absolutely.
And how we can sort of bridge this gap between research and understanding its relevance and real world application, particularly as it relates to patients and patient groups. So let's start with the most basic KT. For audience members who are not familiar with the terminology, Dr. Pope, what is knowledge translation and exchange?
Right. So some people used to maybe be more familiar with KTE. It's the same thing. So knowledge transfer and exchange. And so the bottom line, and I'll quote from Confucius first. So I stole this quote as I was doing research. Confucius said, knowledge without practice is useless. So if we don't disseminate it, waste of time. But practice without knowledge is dangerous. So there are
Right.
so many studies going on that it is really important that we get the knowledge into the hands of the consumers, i.e., the patients who have to deal with the problems, to the physicians who are treating the patients and other healthcare providers. It goes beyond the physicians, the pharmacists, the therapists, et cetera, and also the policymakers so that we can get access where appropriate to proven good therapies. So what is really true is that it is almost impossible for an even conscientious patient or consumer and or a conscientious healthcare provider to know everything about a certain area. There's just too much happening. So the knowledge translation really should be part of the dissemination of ideas and information, and it should go beyond a peer-reviewed journal. It really should, because in this day and age, we need other channels to get it into the hands of the right people. And the channels might be social media, it might be podcasts. So the CRA does podcasts. It might be other channels where public forum or speaking or at the CRA talks and posters to really disseminate what's important. So I've given a few ideas, but it really can't just be the old fashioned. We put it in the journal, everybody reads it. Wouldn't that be pie in the sky? Everyone reads it and then we all change our behavior.
Exactly. And maybe, I mean, that's what a successful exchange would look like. What are the risks if these research findings are not effectively disseminated or shared? Going back to, I guess, the old days as you described them.
Right. So I think there is a high risk because, first of all, research that's involving humans We've put people through things for, to be they're donating their bodies, their time, their energy. But even if it's basic science research, if we do that in a vacuum and we don't inform the target audience appropriately, and it takes a lot to inform people. You usually have to disseminate amongst different ways and do it frequently enough. The risk is the research was a waste of money then, waste of time, a waste of money, because we don't change our behaviors or go to the next step. And science is all incremental. There's sometimes the giant leap, but most science is little steps going forward, one on top of the other. And as stats have shown, that only about 14% of research is translated into action, and that it takes sometimes 1.5 decades for this to happen. So we're kind of slow learners in the scientific method of, at least from the physician perspective. We have to hear things repeatedly. We have to get it into guidelines where appropriate to change our behavior. And we have to have a critical mass of similar findings before we start saying, oh, I think I'm going to start treating my patients in this new kind of way, unless if I feel that the bulk of the data will support this, unless, of course, if it's transformational. Some biologics, when they first came out, say in rheumatoid arthritis, were transformational. So we wanted to get them into the hands of the treating physicians and into the patients as quickly as possible. But lots of treatment is or knowledge is just incrementally more helpful, but it's a difficult task. But that's the downside. If we don't do that, we don't change our ways of practice and we don't help people more, or we don't change for policymakers, or we don't inform patients to actually ask and have a dialogue with whoever is following them for their disease of interest.
So, helping promote research into action, I think we heard you say. Maybe you could provide us some examples. You touched on biologics. Touch on some examples, maybe that was biologics was 20 years ago, but say in the last couple of decades and most recently, can you give us some examples of really effective, successful knowledge translation efforts that have led to the type of improvements in patient care you're describing?
Right. So fortunately, there are many. So that's the good side of things. And
Yeah,
often it's because guidelines have come out and then they really are something that if you're not an expert in a subspecialty area that you can look at and follow. So I'm going to give you a couple recent things. So
sure.
in lupus nephritis, so kidney inflammation, kidney involvement in our lupus patients, guidelines came out within the last year, and they really said um, our current care up till now has been not good enough for the majority of patients. That we would have people suffering with kidney nephritis, lupus nephritis. About 1/3 of them would get end-stage kidney disease in the next 2 to 5 years. That is unacceptable. And now that we have proven treatments, proven beyond a reasonable doubt, that combining in early lupus nephritis treatment, less prednisone over time, continuing and using the mycophenolate mofetil or cyclophosphamide, preferably MMF, mycophenolate mofetil, or it's known as Cellceptor Myfortic, because it's a bit safer. And here's the new part, and adding in severe kidney lupus class 4 or 5 on kidney biopsy. So they're the ones we will treat effectively and aggressively and had treated like that before that I mentioned, to really add another proven standard of care. And that could be calcineurin inhibitors. So in Canada, that would be something like tacrolimus, rarely cyclosporin, or belimumab, which has data and more data coming. So I'm going to paraphrase because they say other things when proven. So obinutuzumab has just gotten positive phase 3 data, and it's a drug that we are familiar with from the oncology side. So 3 drugs, less prednisone, an immune suppressant, and now adding another immune suppressant is better than not adding the new immune suppressant right from the beginning. So that is transformational. I already, because of being in this area of research and expertise in lupus, I already was doing that the last few years, but usually arguing with a nephrologist, and now we're all on the same page. So that's basically, it is transformational, and we put more people into kidney lupus remission by doubling, like giving two immune suppressants at the beginning, and all the other good standard of care, blood pressure, cholesterols. One of the new diabetes drugs can also help proteinuria. These drugs are now becoming standard of care if a lupus patient without diabetes has they're leaking out a lot of protein in their urine. So all this has really changed, sort of right an about face, which is pretty cool. What about another area? The use of prednisone. So glucocorticoids are prednisone in giant cell arteritis, or we also call that GCA, or
Mhm.
temporal arteritis. That's the headache, maybe jaw pain with chewing your food, or tongue pain with chewing your food, severe scalp tenderness, and other things that can occur. And we now have, for a while, we've had access to the IL-6 inhibitor called tocilizumab. The trade name is Actemra, and now there's a biosimilar approved in
Mhm.
Canada, and showing that if we use proven therapies, we can spare the amount of prednisone. And there's Canadian data that results in less hospitalizations, because prednisone increases the risk of infection, can give osteoporosis and fractures, cataracts, diabetes, high blood pressure, delirium, all sorts of things on the high doses that we were using in these patients, because they need on average treatment for 2 years and some of them for longer, with high or moderate dose of prednisone until we're able to taper down. There's also a positive trial, so not yet approved in Canada, but with an oral agent, upadacitinib, in this area. In
Mhm.
the spectrum of GCA, we now have approval of other drugs in polymyalgia rheumatica if we're unable to lower the prednisone down. And those approvals for polymyalgia rheumatica and for the upadacitinib, a JAK inhibitor, and GCA should come in the near future in Canada, and already it's changing our practice. So there's just two good examples of perhaps less common diseases than what, in rheumatoid and psoriatic and axial SpA, but all these things are really changing what we do. And I think it's so important that they are.
Yeah, that's a great summary and good examples. And I think all I would add there is that these treatment guidelines, which you could find on the CRA's website, the Canadian Rheumatology Association website, are obviously being integrated into clinical practice. But for patients to know and understand, let's say in the example of lupus, they could go to Lupus Canada, they could go to Arthritis Consumer Experts websites, and they'll find information about those treatment guidelines, and oftentimes translated into language that's a little easier to understand. And most importantly, for them then to be able to have a really good conversation with their specialist.
Right, right,
Yeah.
absolutely. And just another a tidbit to tell you. So the lupus guidelines are being updated in Canada. Dr. Stephanie Keeling is spearheading that with a large
Indeed.
group. And so they will be on the Canadian Rheumatology Association website probably in about a year. The other thing is something that's important for psoriatic arthritis, axial SpA, so that's spondyloarthritis or ankylosing spondylitis. The ankylosing spondylitis treatment guidelines were just updated. That's my colleague, Dr. Sherry Roecker. I sit next to her in clinic. I talk to her every day. So they are on the website. And the final thing is the rheumatoid arthritis guidelines are being updated, parts of them every now and then,
Right.
ongoing. It looks like now and then, but it's a continuous process. But what's new there for knowledge translation is being considered in guidelines. How do we disseminate what should be the standard of care for referring physicians, policymakers, patients, non-rheumatologists, et cetera? And also, how do we incorporate the lens of equity, diversity, and inclusion,
Mm.
as most guidelines, until we get now to these Canadian guidelines, have never really looked at that, because it's unfair not to have access to something that's proven if others do in the same situation, the same country, or the same province, or the same community. So that's also
Absolutely.
And that's really, I think, where knowledge translation will help us with data to show that we need to have fairness. That's so obvious, but we can have data to prove that if people are denied drugs or it takes longer to get them or they don't have a good reimbursement pathway in some situations, that they won't do as well.
We're going to have links to some of those, for instance, treatment guidelines and other examples of KT in practice at the end of this episode, so people can look at that. I'm not promising that we'll have the Confucius reference, but I'll look for that as well. And then finally, to sort of wrap this up, in your position as an international leader, but also somebody who is working with people who are just starting their early careers in research, what kind of advice would you give them on integrating KT into their research plans from the start? And I'm thinking particularly of including the engagement with patients early on.
Right. So first of all, there are many grants that appropriately say, we will fund you, but we want a team, including the patient voice. And the patient voice could be someone on the team, not just I don't mean tokenism at all. I mean someone that will provide input or more than someone. It can be more than one person for sure. But also there's other ways. There can be patient surveys, online ways of finding out what's more important, A or B. So our scleroderma online group, the SPIN cohort, which is scleroderma patient. It's an international network. They're right now researching itch because that's really important when your skin is inflamed and tight and you can get ulcers and things like that. But itch was never really in our questioning of patients. It's asking them what's important to you. That's just one example. So as an example for young investigators, I would say number one, get on social media. It's free and you can inform people. Number two, do it regularly, do it often, and do it in a way that lay people can understand. And also, you can get out there. Pictures are worth more than words, and some people, how they learn. So we try to get now, I try to advise the young ones and myself as well, because I have to change my ways, to have pictograms. So pictures of what's like these few words and conversation and dialogue that are important for the bottom line of a study. And so less might be more. So having something that really says two key points or a picture of a graph, and here's why it's important. Those sort of hits with our kind of ADD world are important for the other, the healthcare workers, for the consumers, meaning the patients, for policymakers, for also educating the trainees. So I think it's important, and not everyone's going to be on, say YouTube, where we have like our catch cohort has over 200,000 views on translation for patients in both French and English. And that's important. And if we have that many views, not on one talk, but on many talks, like combined, it's because it's important for people living with arthritis. So I think all those things can only help to get the word out there and to get a consistent, easy message.
And maybe just a shameless spot here of self-promotion. One more piece of advice for those people starting their careers: get to know and partner with patient groups, and contact arthritis consumer experts as an example. Probably the largest active social media network in Canada for arthritis and patients. So we've got a big megaphone, and we're always interested in collaboration and opportunities with KT. Dr. Pope?
Yes, absolutely. Yes, I fully agree about the ACE comment. You're allowed to promote that. It's true.
Thank you. And thank you for joining us today, Dr. Pope. We really appreciate it, and good luck at the conference.
Okay, thank you, and good luck with all the work you're doing. Keep it up.
Thanks, Dr. Pope. And thanks to you, everyone who's watching. We look forward to sharing more of the exciting science from the CRA meeting in our next episode of #CRArthritis. Bye for now.